entitled Authority to Cure by Body Invasion, not only a matter of court and seal, to be delivered by a distinguished Professor of General Surgery, Professor Babatunde ADETERU AYOADE. Please, can we give him a round of applause? But like I mentioned earlier, the procession is about to enter the hall. Can we all now rise as we welcome the academic procession of the distinguished principal officers of this great university, another distinguished academic of OLABISI University, Professor Rasak Olawole Ojunaike, is closely followed by the acting dean faculty of Environmental Studies, Professor Dr. Abiodun Oyinloye, is followed by the acting dean faculty of Engineering, Dr. Abayomi Layeni. Dr. Abayomi Layeni is followed by the dean faculty of Agricultural Production and Renewable Resources, Professor Akim Awujobi, is closely followed by the dean faculty of Agricultural Management and Rural Development, Professor Diran Awutude. Next to him is the dean faculty of Arts, Professor Samson Dare. Professor Dare is followed by the dean faculty of Pharmacy, Professor Latif Sakal Kasim. Of course, he's supposed to be followed by the dean faculty of Clinical Sciences, Professor Babatunde ADETERU AYOADE. Today is the inaugural lecturer. The next person to him there is the acting dean faculty of Basic Clinical Sciences, Dr. Wasiu Eniola Oluto. Is followed by the dean faculty of Basic Medical Sciences, Professor Mrs. Arnold Tula Mopelola Pechi Abuola. Next person to her is the dean faculty of Science, Professor John Abidemi Lawi. And of course, the acting dean faculty of Law, Dr. Obade Akinrimade. The next person to him there is the dean faculty of Education, Professor Dekini Obutimeni. It's closely followed by the dean faculty of Social Sciences, Professor Ayodele Odulami. Professor Odulami is followed by the dean faculty of Administration and Management Sciences, Professor Musef Sholange. Next person to him is the acting provost, College of Engineering and Environmental Studies, Professor Bashir Odufuwa. Next to Professor Odufuwa is the provost, College of Agricultural Sciences, Professor Adewale Onosanya. Adewale Onosanya is supposed to be followed by the dean, the provost of Ademi Awolowo College of the Sciences, Professor Musili Petuga. And of course, the provost, Postgraduate School, Professor Olusegun Adebayo Lawal. Next person to him there is the bursar, Mr. Femi Showunmi FCA, who is ably represented by Mr. Tinitope Obinidi FCA. The next person to him there is the University Librarian, Professor Peritola Ike Onifade. She's followed by the Registrar of this great university, Mr. Femi Ogunwoju. And of course, the Deputy Vice Chancellor Administration, Professor Charles Olufemi Adekoya. The next person to Professor Adekoya is the Deputy Vice Chancellor Academy, Professor Olatunde Abosede Oderinde. And of course, the inaugural lecturer of today, Professor Babatunde ADETERU AYOADE. And of course, he's been honored by our amiable Vice Chancellor, Professor Ayodeji Olayinka Johnson Agbola. Can we give the procession a good round of applause? Thank you very much. Distinguished members of the high table here, distinguished members of the audience, may I now invite the Registrar and the Secretary Council of OLABISI University. Please, let's have our seat. Distinguished ladies and gentlemen, once again, may I now invite the Registrar of this great university, Mr. Femi Ogunwoju, who in turn will invite the Vice Chancellor of this great university, Professor Ayodeji Agbola, to formally declare the professorial inaugural lecture open. Thank you very much, Mr. Registrar.
Distinguished ladies and gentlemen, once again I welcome you to the 107th inaugural lecture of the OLABISI ONABANJO University. May I now invite the Vice Chancellor to please declare this inaugural lecture open. The Vice Chancellor.
The Principal Officer of the University, Provost, Deans, Professor here present, Member of Senate, other university community here present, guests and the inaugural lecturer of today, ladies and gentlemen, on behalf of Senate of this university, I hereby declare 117 inaugural lecture open.
Distinguished ladies and gentlemen, today's 117th inaugural lecture will be delivered by Professor Babatunde ADETERU AYOADE. The title is Authority to Kill by Body Invasion, not only a matter of court And so, may I please request Professor Babatunde AYOADE to please stand and remain standing. The Vice Chancellor will now introduce the inaugural lecture. Vice Chancellor.
Distinguished ladies and gentlemen, I have the pleasure of reading the citation of Professor Babatunde ADETERU. Was born on the 28th of March 1956 in Abeokuta to the family of late Chief AYOADE and late Mrs. Susanna AYOADE of Omosaju Compound, Totoro, Owu, Abeokuta. He had his primary education at Owu Baptist Day School, Totoro, Abeokuta, and the Christ the King Government School, AGO-IWOYE. He had his secondary school education at the Government College, Ibadan, from 1969 to 1973. And thereafter, he had his advanced level education from 1973 to 1975, during which he won the Western State Government Scholarship for that period. He proceeded to the University of Ibadan, where he studied medicine and obtained the MBBS degree in 1980. Again, he won the Ogun State Government Merit Scholarship during the clinical years in the university. These are testimonies to this exemplary academic goals. Trying to create a need for himself in the field of medicine, in general surgery as his area of specialization, the young AYOADE in 1987 proceeded to Obanfemi Awolowo University Teaching Hospital Complex Ilefe for postgraduate medical training. This culminated in the award of prestigious fellowship for the West African College of Surgeons by examination in 1993. In the year 2002, he proceeded to the Royal College of Surgeons in Ireland, where he obtained the fellowship from the Royal College of Surgeons in Ireland by examination as well. Professor Babatunde ADETERU started his professional career as an intern at the State Hospital in Laro and in Ijebu-Ode between 1980 and 1981. He did his national youth service at the staff clinic Lagos State Government in Kenya between 1981 and 1982. He worked severally as a medical officer at the State Hospital in Laro and District Hospital Odo-Ogoru, Ayegbe between 1982 and 1987. Following his postgraduate medical training between 1983 and 1993, he worked as a consultant general surgeon at the State Hospital Abeokuta in 1997. He also worked as a general surgeon at the Queen Elizabeth II Hospital, Lesotho, till 2003, and during this period, he received clinical training in endoscopy at the Department of Surgery, Universitas Hospital in South Africa. Still outside the shore of Nigeria, he worked as a consultant general surgeon at the General Hospital, Rafah, Kingdom of Saudi Arabia, between 2010 and 2011, where he served as the head quality assurance medical unit. In the academia, he was appointed lecturer 1 in August 2003, and through the days of hard work, he rose through the ranks till he reached the pinnacle of his academic career in 2020, when he was appointed a full professor in this university. He is a member of several committees in the Faculty of Medical Sciences, College of Health Sciences, as well as within the university. He was also the departmental coordinator of Congress between 2011 to 2018, and acting head of the Department of Surgery between 2018 to 2021. And thereafter, he was elected the Dean of the Faculty of Medical Sciences of Bafin and Awolowo College of Sciences in August 2023. Professor Babatunde Adeteru AYOADE belongs to several professional bodies such as the Nigerian Medical Association, the Medical and Dental Consultants Association of Nigeria, where he was the chairman of the OLABISI ONABANJO University Hospital Shagamu chapter between 2012 and 2014. After his tenure as the American chairman, he has served the association in several other magnificent capacity, including the building committee. He is also a member of the Nigerian Surgical Research Society, Nigerian Cancer Society, American Society of Medical Oncology, European Society of Medical Oncology, and of course, the African Organization for Research and Training in Cancer. Given his studying experience with postgraduate medical training, he has trained several generations of residents in the Department of Surgery, OLABISI ONABANJO University Hospital Shagamu. He has trained up to the level of post education, 4 general surgeons, 3 urological surgeons, 3 pediatric surgeons, and at least 3 orthopedic surgeons. He is currently an active member of the West African College of Surgeons, where he is an examiner at both the membership and fellowship levels. He has also served as a member of the Accreditation and Decision Panel of the West African College of Surgeons to several teaching hospitals in West Africa sub-region. Our inaugural lecturer of today is an active clinical researcher. His research interest is in surgical oncology, and he has distinguished himself in academics and general practice in matters of breast malignancies. He has over 40 publications in reputable local and international medical journals to his academic proficiency. He has also attended several local and international conferences, trainings, and workshops. He is also a reviewer of many reputable medical journals, including the Nigerian Journal of Surgery, Nigerian Journal of Clinical Practice, Annals of Health Research, and Sahara Medical Journal. Professor Babatunde Adeteru AYOADE is not only an academician, he is a family man. He is married to ADETERU AYOADE, a retired head of Nursing Services Department at the OLABISI ONABANJO University. The marriage is blessed with 3 beautiful children and grandchildren. Ladies and gentlemen, it is my pleasure to invite Professor Babatunde Adeteru to the podium to give 117th inaugural lecture of today.
The Deputy Vice Chancellor, Academic, the Deputy Vice Chancellor, Administration, other principal officers of the university, Provost of the postgraduate school and colleges, Deans of faculties and student affairs, distinguished professors, serving and retired, heads of department, KBSC, our royal father, my senior colleagues and colleagues, my lords, spiritual and temporal, family and friends, distinguished ladies and gentlemen, gentlemen of the press, great OUIs, great comsites, Mr. Vice Chancellor, I return all honor and glory to Almighty God, who made it possible for me to stand before you all today to deliver the 117th inaugural lecture of our great university, the 27th from Obafemi Awolowo College of Health Sciences, the 18th from the Faculty of Clinical Sciences, the 4th from the Department of Surgery, and the 2nd by a general surgeon in this university. I pay tribute to my surgeon colleagues from the Department of Surgery who have stood on this podium to deliver similar lectures in the past in the persons of Professor A.M.O. Sholubi, Professor L.O.A. Tani, and then Professor A.O.Tade of Blessed Memory. And I feel immensely grateful for the opportunity to do so. This event fulfills a lifelong aspiration to be an accomplished surgeon, despite all odds. I'm particularly grateful to the Vice Chancellor, Professor AYOADE Johnson, who graciously approved this ceremony and played a vital role in my journey to this point, right from the time when he invited me to join his research team. An inaugural lecture is a direct ode to the university community by any academic once risen to the position of professor to describe the philosophy of their research activities. I stand here today to pay that debt. And I intend to do it in the most straightforward language possible. This lecture aims to showcase the academic values of our modest contribution to the practice of general surgery, and in particular, the management of some life-threatening conditions, to highlight some of the challenges faced and some peculiarities of our operation that led to undesirable outcomes. What is surgery? The first recorded definition of surgery in 30 AD was by Celsus in his introduction to Book 7 of The Medicine, in which he stated as follows: the top part of the art of medicine is that which cures by hand. It does not omit medicaments and regulated diet, but does most by hand. The effect of this treatment are more obvious than any other kind, inasmuch as in disease, since luck helps watch, and the same things are often salutary, often of no use at all. It may be doubted whether recovery has been to medicine or a sound body or good luck. Besides, in cases where we depend chiefly upon medicaments, although an improvement is clear enough, yet it is often clear that recovery is sought in vain with them and gained without them. But in that part of medicine, which cures by hand, it is obvious that improvements come chiefly from this, even if be assisted somewhat by other ways. This statement is as true today as it was many years ago. Today, surgery is defined as a branch of medical practice that treats injuries, diseases, and deformities by physical removal, repair or readjustment of tissues and organs, often cutting to the body, perceived by ordinary people as cut and sew. The surgeon has the authority to cure by body invasion, subject to the patient's consent. Surgery is not only a matter of cut and sew, as it involves making a diagnosis, determining the type of operation, and making the patient ready for the surgery, aftercare, and sometimes lifelong follow-up. The art of surgery can be conceptualized as when to cut, why to cut, who to cut, what to cut, and how to cut. The art of surgery can also be classified into 4 major categories. 1, wound treatment, which deals with tissue injuries, either deliberately made, as in surgical operations, or accidental following mishaps. 2, extirpative surgery, which is done for the removal of tissues which may be dead, dying, dangerous, as in cancerous, or damn nuisance. 3, reconstructive procedures, done to restore both form and function of some parts of the body by utilizing available healthy tissue. And 4, transplantation, which entails the replacement of a diseased organ with another organ procured from a donor. There has been a tremendous development in the field of surgery, which makes all this possible. History of surgery. The oldest book in the world is a treatise on surgery, the Edmund Papyrus, composed in 1600 BC and discovered in 1862. It is an incomplete scroll written around 3000 BC in ancient Egypt, in which 48 cases were described almost in modern form. It revealed that ancient Egyptian surgeons could treat head injuries, wounds with suturing, or adhesive bands, and fractures by reduction and immobilization. In Babylon, surgery was well organized, such that King Hammurabi, 1948 to 1905 BC, drew up a code for medical practice that regulated fees for successful treatment and penalties for failures. And I quote, "If a physician shall make a severe wound with an operating knife and kill him, or shall open an abscess with an operating knife and destroy the eye, his hand shall be cut off." Unquote. The Greek physician Hippocrates, 460 to 377 BC, and the father of medicine wrote the surgical treatise Corpus Hippocraticus, which showed that their treatment of fractures and dislocations was based on good knowledge of anatomy and physiology. His method of reduction of shoulder dislocation is still practiced today. During the Middle Ages, surgery was predominantly carried out by barbers and others non-medical professionals. However, in the 16th and 17th centuries, the development of anatomy and anesthesia facilitated the development of advanced surgical procedures. The factors that aided development and evolution of surgical practice today are the conquest of pain by anesthesia, infection control by aseptic techniques, bleeding control, and blood transfusion. In the 20th century, progress in technology and medicine culminated in the development of new surgical techniques such as minimally invasive surgery, robotic surgery, and organ transplantation. The discipline has evolved into a highly sophisticated field that treats various medical conditions with different procedures, different specialties in surgery. Apart from the well-known general surgery, other surgical subspecialties include pediatrics, cardiothoracic, urologic, orthopedic and trauma, gynecologic, plastic and reconstruction, ophthalmology, otolaryngologic surgery, and neurosurgery. This is not an exhaustive list, because some of these have also evolved into some subspecialties. My choice of general surgery as a specialty. My early exposure to good surgical practice is State Hospital Laro, first at a house hospital under Dr. Kule Obadilo, who is in the audience. An American trained general surgeon who will anesthetize the patient and carry out the surgery with excellent results, with near zero morbidity and mortality. I was so impressed with this experience that I decided to specialize in surgery. I therefore returned to the same hospital in 1982 after my NYSC as a medical officer in the surgery department to continue serving the compulsory 4-year bound in respect of the state scholarship award I received during my undergraduate medical education. Interestingly, some of my classmates who enjoyed the same scholarship as I did declined to hold on to the agreement. My hero, Dr. Kule Obadilo, left government service shortly after. He was replaced by Mr. Sholata in FRCSI, who also left after a short period, and Dr. Akim Olusmadi replaced him. These two great surgeons gave me the necessary guidance and encouragement to pursue a career in surgery. They greatly assisted me when I had challenges getting to the residency training program, despite passing the primary examination in surgery in November 1984. I had a personal experience in June 1987 that further convinced me of the need for specialist medical training. I had my first child, who was delivered in a private hospital by vacuum extraction, performed by a gynecologist, and subsequently developed a family hematoma. That's some kind of blood collection on the head. As part of the care, the baby was transfused with blood and was later discharged to recover at our home in the doctor's quarters in the district hospital where I was the medical officer in charge. At home, I noticed her breathing was fast, unlike what I had observed in other babies delivered in our hospital. So I invited my friend and senior colleague, Professor Joe, who is in the audience, then a young consultant pediatrician to help evaluate her. My friend made a diagnosis of congestive cardiac failure. That's heart failure. Secondly, to circulatory overload, too much blood was transfused. He promptly instituted appropriate treatment, which was followed by dramatic improvement and complete symptom resolution in a matter of 2 days. The child is 36 years old today. The die was cast. I resolved to pursue specialist training to a logical conclusion. I therefore proceeded to Obafemi Awolowo University Teaching Hospital Complex for the residency training in general surgery. My journey to academic surgery. I joined the services of OLABISI ONABANJO in year 2003 as a lecturer in general surgery. Following my return from my 6 years of tour in Lesotho, Southern Africa, I remember the then provost of our College of Health Sciences, Professor Oyebule, asking me if I realized the drastic change in career path I was making. Still, I had made up my mind to join academics despite mouth-watering offers from various places. Upon resumption, I quickly settled in, and I must say I have no regrets whatsoever about that decision. As a general surgeon, one deals with many common general surgical conditions and sometimes takes on the responsibility of other surgical specialties if the expertise is unavailable, including teaching, akin to being a jack of all trades but master of some. My research revolves around general surgery with an emphasis on surgical oncology, determinants of mortality among surgical patients, review of surgical procedures, acute and palliative care. I therefore will explain and discuss some aspects listed above, as I have refused the temptation to stand here and talk only about breast cancer. Surgical oncology. This branch of surgery focuses on treating cancers, treating tumors, particularly cancer. It includes various aspects of diagnosis and intervention, including total removal of destruction and palliative procedures. Now, understanding cancer. Cancer arises from cells, which are the building blocks of tissues that form organs of the body. Cells are formed in the body as they are needed. Old cells die and they are replaced by new ones. This orderly process sometimes goes wrong when cells are formed when they are not needed, or old cells refuse to die. These abnormal cells form a mass of tissue called a growth or tumor. A tumor can be malignant or benign. Benign tumors are not cancers. They are often not life-threatening. They do not recur after removal. These cells do not invade surrounding structures. The cells do not stretch to other parts of the body. Whereas malignant tumors are cancers. They are usually life-threatening. They recur after removal. The cells invade and damage surrounding structures. These cells spread to other parts of the body, that is metastasize. This occurs when cells break free and enter the bloodstream or lymphatic stream, through which they reach other parts of the body, a process known as metastasis. Cancers are named according to the site of the original tumor, the primary. Examples are breast cancer, liver cancer, colorectal cancer, brain cancer, and lung cancer. These features of cancers are responsible for the overall manifestation and treatment outcome in people afflicted with the disease process. How cancers produce disease. Disturbance of function of the organ of origin, invasion of surrounding structures with impairment of their functions, and finally spread to distant organs, also with impairment of their function. This process eventually leads to failure of the vital organs, resulting ultimately in death. It is apparent that the longer the cancer is left untreated, the more dismal the treatment outcome. This is because a stage is reached where all the treatment modalities available will not control the disease. Anatomy or structure of the breast. The breast is an organ of secretion that develops from modified stomach glands located beneath the nipple. It is made of 5 to 20 sacs known as lobes, and each lobe comprises of smaller milk wells known as lobes, which are connected to the pores or holes on the tip of the nipple through pipes known as ducts. The adult breast extends from the 2nd to the 6th degree on the chest wall and it lies on layers of soft tissue, the deep fascia, and muscles, the pectoralis muscles. The breast reaches nearly to the midline in the front and continues backwards towards the armpit. This part is known as the breast axillary tail. The structure recognized as the breast is made up of the big milk-producing glandular tissue and the surrounding fat. The breast undergoes structural and functional changes throughout puberty, pregnancy, lactation, that's breastfeeding, and to a lesser extent throughout the menstrual cycle, due to changes in the amount of circulating chemicals known as hormones circulating in the blood. Physiology of the breast. Numerous chemicals known as hormones such as cortisol, growth hormone, thyroid hormone, oxytocin, progesterone, prolactin, and estrogen trigger breast development and function from puberty. The main hormonal inducer of breast milk production in the later stages of pregnancy and following childbirth is prolactin. The hypothalamus is a part of the brain which indirectly regulates hormones which have effect on the functions of the breast, such that emotions affect breast milk production. Breast symptoms. I started my foray into surgical oncology by investigating the common breast complaints in a clinical setting. The study conducted among women in Shagamu found that a lump in the breast was the most common breast-related symptom, and when the lump is painful, malignancy should be suspected. AYOADE 2012. Other symptoms of breast disease include pain, swelling, nipple discharge, nipple retraction, skin changes, and a lump under the armpit. Breast symptoms are very important as their appearance may signify the presence of a very serious disease like breast cancer. In the West, the most common breast complaint is pain. In contrast to what was found in my study of patients with breast complaints in Shagamu, Nigeria, pain is a noxious stimulus which often signifies tissue damage and often makes the sufferer seek early treatment. In my study, breast lumps, which later became painful, were associated with malignancy. The importance of this observation is that the presence of a palpable cancerous lump is an indication of an advanced disease, advanced breast disease, and a poor prognostic sign. In our population, there is a tendency to ignore lesions that are not painful, therefore allowing the lesion to progress to a stage where management becomes difficult. Although the commonest type of breast lump is fibroadenoma, a benign disease, all lumps in the breast must be subjected to histological analysis to unravel their nature. They must be looked at under the microscope. Other benign breast conditions include fibroadenosis, duct ectasia, galactosis, traumatic fat necrosis, and gynecomastia. All these breast diseases must be differentiated from breast cancer. It is important to note that these breast benign lesions, except gynecomastia and enlargement of the male breast, occur principally in females, but malignant breast disease affects both sexes. Breast cancer. Breast cancer is the most common female cancer diagnosed worldwide in the year 2020 and is ranked the fifth cause of mortality worldwide. Some report 2020. About 2.3 million breast cancer cases were diagnosed in the year 2020, which was approximately 11.7% of total breast cancer incidence. The female breast cancer was the cause of 684,996 deaths in the year 2020, some report 2021. The incidence of breast cancer is higher in the developed world, but morbidity and mortality from the disease are higher in the developing world, typically for 2018. In year 2020, breast cancer was the most common cancer and the leading cause of cancer deaths in the general population in Nigeria, WHO 2020. Mr. Vice Chancellor, sir. Our local experience with the incidence of breast cancer is not different from the above. In a screening program of the Medical Women Association of Nigeria, M1, in the 3 senatorial districts of Ogun State involving 2,450 women. 102 women were referred to us for breast biopsy, of which 21, as in 20.6%, turned out to be malignant. AYOADE of 2019. In that study of 121 patients presenting with breast complaints, 36.4 had a clinical diagnosis of breast cancer. AYOADE of 2012. Of 2,946 surgical admissions over 4 years, 279 were for malignancies, and 165, that is 59%, of these were breast cancer cases. AYOADE of 2017. The incidence of breast cancer is increasing in our population, and many reasons have been adduced for this. These reasons include increasing life expectancy, adoption of some cancer-promoting Western habits like alcohol consumption, short breastfeeding periods, and increasing availability of diagnostic facilities. Risk factors for breast cancer. The exact cause of breast cancer is not known. This is still a subject of many ongoing intensive research. However, the risk factors are well known. This includes sex. Breast cancer predominantly affects women, and only about 1% of cases affect men. In a study of 139 patients, all the cases were female. AYOADE of 2014. Age. The chances of getting breast cancer increases with age. Most Caucasian women are aged 60 years and above when they are diagnosed. However, in a study, the mean age presentation was in the mid-40s, which is similar to the observation of others. The reason for this pattern is that developing countries, on average, have a high fertility index and a low average life expectancy, and this may account for a relatively higher proportion of young women with breast cancer. Personal history. Having breast cancer in one breast increases the risk of getting cancer in the other breast. Others have certain types of abnormal breast cells, such as aplasia, tubular carcinoma in situ, or ductal carcinoma in situ. This increases the risk of invasive cancer. These conditions can be found with breast biopsy. Family history. The risk of having breast cancer is higher if a mother, father, sister, or daughter has breast cancer. The risk is even higher if a family member had breast cancer before the age of 50 years. Having other relatives in either mother's or father's family with breast cancer or ovarian cancer may increase the risk. In our study, 9% of 139 cases of breast cancer had a family history of breast cancer. AYOADE of 2014. Certain genomic changes. Changes in specific genes like BRCA1 and BRCA2 substantially increase the risk of breast cancer. There are tests. Tests can sometimes show the presence of these rare specific genes, gene changes in families of many women who have had breast cancer. Radiation therapy to the chest. Women who have had radiation therapy to the chest, including the breast, before age 30 are at an increased risk of breast cancer. Reproductive and menstrual history. The older a woman is when she has her first child, the greater her chance of breast cancer. Women who have never had children are at an increased risk of breast cancer. Race. In the United States, breast cancer is diagnosed more often in white women than African American, Black, Hispanic, Latina, Asian, Pacific Islander, or American Indian, Alaska Native women. Breast density. Breasts appear on mammogram, that's breast X-ray, as having tissue, as having dense and fatty tissue area. Women whose mammogram show a larger area of dense tissue than the mammogram of women of same age are at an increased risk of breast cancer. Being overweight or obese after menopause. The chance of getting breast cancer after menopause is higher in women who are overweight or obese. Also, in our study of 139 patients of breast cancer, 16.1% were overweight or obese. AYOADE of 2014. Lack of physical activity and drinking alcohol may predispose to etiological factors involved in breast cancer. Clinical manifestation of breast disease. Breast cancer is asymptomatic at the stage when it is curable, and the prognosis is worse in the advancing stage of the disease, as previously mentioned above. Late presentation is the rule in our environment, as revealed in our study of 113 patients, where only 26.5% presented early, AYOADE from 2015. Most of the cases in our cohort presented with large lumps, breast ulcers, breast pain, and symptoms of spread to other organs in the body. Our team reported a case of breast autoamputation following the neglected breast cancer in the affected breast. A study of factors associated with late presentation in our study cited above showed rural residency, fear of mastectomy, surgical removal of the breast, the notion that surgery aggravates breast cancer, treatment by traditional healers, and prior breast cancer knowledge. AYOADE from 2015. Yeah. Now, this is a picture of a patient with bilateral breast cancer she declined surgical treatment, but got pregnant after the diagnosis was confirmed and chose to receive treatment in a church. Treatment of breast cancer. Mr. Vice Chancellor, breast cancer treatment should be done by a multidisciplinary team consisting of surgeons, pathologists, radiotherapists, medical oncologists, physiotherapists, pharmacists, radiologists, and oncology nurses. Kitting et al. 2012. The treatment includes local regional disease control, systemic recurrence prevention, and metastasis control. Local regional control, which is the treatment of the affected breast and axilla, can be achieved by surgery, with or without radiotherapy. In contrast, prevention and control of systemic disease is usually accomplished with chemotherapy, which is the use of drugs to kill cancer cells and the use of biologics or hormone therapy. Chemotherapy or radiotherapy may be administered as adjuvant or neoadjuvant, that is, after or before surgery, to reduce the recurrence of the disease. Therefore, it is not only a cut and sew matter. In our environment, a large percentage of tumors are inoperable at the time of diagnosis due to delayed presentation, and thus require other measures in addition to surgery. This is important as breast cancer is considered a systemic disease once the lesion is palpable in the breast. In our local practice, radiotherapy is unavailable, hence patients requiring radiotherapy are referred to centers where it is available. Nonetheless, chemotherapy is administered by the surgical team. Response to chemotherapy in breast cancer depends on the drug and the biological characteristics of the tumor. Outcome of treatment. The most important prognostic factor in breast cancer is the stage of the disease at the time of diagnosis, as survival is dependent on this factor, provided adequate treatment is given. The 5-year survival in breast cancer is about 80%, and this decreases as the stage advances. Our population's 5-year survival is very low due to late presentation and other mitigating factors. In our study of 139 patients, the 3-year survival rate was only 45.2%. This is obviously dismal. Some prognostic factors, including histologic type, histological grade, tumor size, and lymph node involvement, both captured in stage. Others include estrogen receptor, progesterone receptor, and human epidermal growth factor receptor type 2 oncogene expression. There are others, but these are just listed these ones. Challenges associated with breast cancer management. Some of the challenges associated with breast cancer treatment in resource-constrained environment like ours include late presentation, high default rate, unfavorable biological subtype, high cost of treatment, inadequate personnel, inadequate diagnostic and therapeutic facilities, and lack of radiotherapy services. The poor treatment outcome is very difficult to justify the cost of treatment, which is very high for advanced cases commonly encountered in our practice. AYOADE of 2014. There is a clear-cut financial toxicity associated with the disease. Modest steps taken to reduce breast cancer mortality in our environment. Mr. Vice Chancellor, sir. Our research team, which was led by your good self, identified a preponderance of high-grade invasive ductal carcinoma, which is ER/PR negative among Nigerian women. This finding suggests a biologically more aggressive form of breast cancer, which is poorly responsive to hormonal therapy. Banjo in 2008. We also established that the biology and molecular characteristics of breast cancer in UK Caucasian women are different from those of Nigerian women. AGO-IWOYE 2008. Histological features such as basal-like triple-negative BRCA1 dysfunction were characteristic of breast cancers among Nigerian women. AGO-IWOYE 2008. These histological features are associated with overall poor survival of Nigerian women in breast cancer. We have also shown that PRS gamma expression, protein expression, and UBC9 protein expression are associated with poor breast cancer treatment outcomes. AGO-IWOYE 2013, AGO-IWOYE 2014. There is also a high expression of PAP1 protein expression in breast cancer of Nigerian women, and this has therapeutic potential, as PAP1 inhibitors can be effective in treating these cases. AGO-IWOYE 2013. Finally, higher expression of P53 in Nigerians compared with UK women, they contribute to the differences in tumor biology. AGO-IWOYE 2014. Our research team established that breast cancer among Nigerians is characterized by late presentation and overall poor survival. AYOADE 2014. It was also noted that identification confers a survival advantage in a cohort of breast cancer patients. AYOADE 2013. Surgery, which includes breast conservation techniques such as local excision, wide local excision, and the various forms of mastectomy, is a principal modality of treatment in our practice. Unfortunately, there is a negative perception of breast cancer treatment by mastectomy in our populace, and this contributes largely to late presentation of patients with breast cancer. Therefore, there is a need to educate the populace on the need for early detection to facilitate the use of breast conservation techniques and breast reconstruction, and to avoid mastectomy as much as possible. AYOADE 2015. Mastectomy is associated with some postoperative complications, including seroma, flap necrosis, hemorrhage, and breast cancer recurrence, similar to what is known in other parts of the world. AYOADE 2020. Chemotherapy, either as adjuvant or non-adjuvant, that is before surgery or after surgery, is necessary to take care of residual micrometastases, which are clinically undetectable metastatic lesions. But the choice of the adjuvant or neoadjuvant therapy does not affect overall survival. However, neoadjuvant therapy has the added advantage of the ability to monitor the response to treatment. The response to chemotherapy depends on the agents used, the regime, and the biology of the tumor. We have demonstrated an excellent response to neoadjuvant chemotherapy on the adriamycin cyclophosphamide paclitaxel regime in a cohort, with complete clinical response in 40%, partial response in 40%, stable disease in 8.6%, and progressive disease in 11.4%. AYOADE 2019, with excellent compliance. The choice of the regime was based on availability, tolerable side effects, and cost, as the medication mentioned above are relatively cheap compared to other agents. As part of the search for predicting the effectiveness of the ACP regime in Nigerian breast cancer patients, our team also studied the pattern of hematological parameters in these patients. It was found that only the PLR, that's platelet lymphocyte ratio, is associated with a complete clinical response to neoadjuvant chemotherapy. Therefore, the study recommended that PLR should be used as part of the routine pre-chemotherapy assessment of breast cancer patients. AYOADE 2019. We also observed that obesity overweight is associated with poor response to the ACT regime in a cohort of breast cancer, Nigerian breast cancer patients, AYOADE of 2019. Cancer screening. Early detection and appropriate treatment have been established as the most effective measure to reduce breast cancer morbidity and mortality. American Cancer Society 2009. Breast cancer usually asymptomatic in early stages, during which it is curing. This is the paradox of breast cancer. Therefore, screening for breast cancer appears to be a viable option in reducing the mortality and morbidity of breast cancer. The Department of Surgery of OLABISI and ONABANJO University Teaching Hospital, OUT, Chicago, collaborates with Medical Women Association of Nigeria and the OOUTH management to conduct yearly cancer screening program for Ogun State citizens across the 3 senatorial districts of the state. The Uplift Cancer Screening Center, OUT, was donated by the Uplift Foundation, a non-governmental organization funded by the former First Lady of Ogun State, Chief Mrs. Olufunso Amosu. The center screens for breast and cervical cancers daily and houses the hospital's chemotherapy unit. Unpublished data from the center shows that between 2017 to 2023, 224 palpable lumps were detected by clinical breast examination of 4,146 women at this center. In addition, there was a steady decline in the number of screening examinations performed and a steady increase in the number of chemotherapy sessions carried out at the center. This is unsurprising as the First Lady, whose foundation funded the screening project, has since left office. Ogun is a virtual oncology clinic established in collaboration with ONABANJO Technologies Limited, Nigeria. Using technology to facilitate online consultation and tumor board meetings. This is achieved using an app called ONABANJO, which is accessible on the App Store. Joint consultations with clinical oncologists are organized for our patients who require such instead of outright referral. There is also a weekly virtual tumor board meeting at which newly diagnosed cancer cases are discussed by a multidisciplinary team consisting of my humble self as a surgeon, a clinical oncologist, a pathologist, a radiologist, and a management plan is decided. Unfortunately, the project has now been stopped due to funding constraints. We have identified some of the challenges facing cancer treatment in a low human development index setting, such as late presentation, high treatment default rate, inappropriate management plans, and overall poor survival. There is a need for overall improvement in the socioeconomic status, quality and frequency of health education programs, organization of cancer screening programs for early detection, affordable and accessible health care. AYOADE 2017. Palliative care. Most cancers in the low-income environment present late at the hospital. The chances of a cure are remote at that time, even if the best treatment is available. For such cases, palliative care is required to improve quality of life and minimize the suffering and emotional disturbances associated with the end of life. Palliative care, as defined by the World Health Organization, is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illnesses through the prevention and relief of suffering by early identification and implicable assessment and treatment of pain and other problems, be it physical, psychosocial, and spiritual. OBET 2002. Palliative care involves improving quality of life and minimizing suffering, but not necessarily prolonging life. OBET 2003. Therefore, palliative surgery is generally defined as procedures carried out to control symptoms and improve quality of life without consideration for overall survival. Now and FWACS 2010. Palliative surgery was helpful in some of our patients with advanced disease. It provided appreciable relief of symptoms with tolerable morbidity. AYOADE of 2019. It is important to add that palliative surgery needs to be scaled up and facilities for less invasive procedures such as endoscopic and interventional radiology techniques must be improved. A substantial fraction of our patients with cancer who presented late benefited from less invasive surgical methods in our cohort, AYOADE of 2019. Oral morphine is also useful in the palliative care of patients with malignancies. Morphine reduces pain remarkably and possibly impacts mood, thereby easing the end of life challenges in malignancy. However, our team reported inadequacies in prescribing this important medication in Shagamu, Fatuga Shekov, 2019. Therefore, the study concluded that there was a need for training and retraining of prescribers, all cadres of doctors, including pharmacists who dispense oral morphine prescriptions and nurses who administer the drug to the patients on the accurate oral morphine prescription and safe use. Other areas of interest in the field of surgery. Patient morbidity and mortality in surgery. Acute appendicitis. Acute appendicitis is the most common surgical emergency worldwide and the same in our population. It is associated with many complications culminating in morbidities such as septicemia, peritonitis, and sometimes mortality. Late presentation of acute appendicitis has been reported to be a cause of significant morbidity in our patients presenting with acute appendicitis in OUTH, AYOADE for 2006. Abdominal injuries. Injuries sustained during road traffic accidents sometimes involve the abdomen, thus affecting some internal organs. Road traffic accidents constitute the most common cause of abdominal injury in children in Shagamu, Ukoro for 2014. A rupture spleen requiring laparotomy was the most commonly injured organ in OUTH. The burden of abdominal injuries can be reduced by improvement in road safety measures, AYOADE for 2006. Also, acute renal failure was the most common cause of mortality from abdominal injuries, AYOADE for 2006. Early presentation in the hospital, prompt resuscitation, and other effective interventions will reduce mortality. Colonic injuries or large intestinal injuries. Colonic injuries are associated with some mortality, and this is associated with shock on admission, degree of fecal contamination, and the severity of colonic injuries. Prompt treatment of shock and minimizing contamination may improve survival. ADETERU 2009. Mortality, deaths. Mortality in the surgical ward may arise from both operative and non-operative care. A review of surgical mortalities in OLABISI ONABANJO University Teaching Hospital show that mortality is not directly related to surgical operation but to non-operative care. And the commonest cause is trauma. AYOADE for 2013. Surgical procedures. Laparoscopic surgery is a relatively new area of surgery that emphasizes minimal access. It uses a telescope and a camera system, a special instrument, to perform surgery on the abdominal cavity. The technique is capital intensive and requires special training, not readily available in developing countries. About 19 years ago, we reported on the feasibility and success of laparoscopic surgery in a resource-limited environment like our country. AYOADE for 2009. The timing of colostomy closure, of temporary colostomy, the timing of closure of temporary colostomy is controversial. Some recommended delayed closure, while others recommend early closure. A review of early and delayed colostomy closure outcomes is comparable in our cohort. Therefore, early colostomy closure should be encouraged because of its advantages, such as shorter duration of admission, early return to work, and no need for prolonged colostomy care. ADETERU for 2011. In the closure of Atman's colostomy, the distal stone is often challenging to identify. Therefore, we have described a simple method of identifying this distal stone, interpreting, thereby facilitating easy closure. Salami in 2015. Our team also reviewed the various methods available for repairing macrostomia, a congenital abnormality characterized by widening of the mouth. It concluded that no single method of macrostomia repair is most acceptable. AGO-IWOYE 2012. Inguinal hernia is one of the common surgical problems treated by surgical repair. There are various methods of repair, but all are associated with recurrence. The gold standard for hernia repair is now Lichtenstein repair, which is associated with very low recurrence rate. In the Lichtenstein repair technique, after the section and removal or reduction of the hernia site, the posterior wall of the inguinal canal is reinforced by insertion of a prosthetic mesh, as opposed to tissue-based repair of the posterior wall in other techniques like the Bassini, shoulders, or the cellar. An audit of Lichtenstein repair of inguinal hernia shows that it's an effective procedure in private clinical experience, and the outcome is comparable with the result of other workers, AYOADE in 2015. Gynecomastia. Gynecomastia is the enlargement of the male breast. This condition may be physiological and self-limiting, but occasionally it may require surgery in the form of subcutaneous mastectomy. The procedure can be performed safely under local anesthesia. In our experience, the surgical repair of bilateral cases of gynecomastia can be done at 2 sittings when indicated. The complications of the procedure were notably minimal and gave an excellent cosmetic effect. Salami in 2015. Acute care. We reviewed the practice of lethal analgesics in acute abdominal pain because of the fear of masking physical signs. We found that it is still widely practiced in a cohort of Nigerian doctors, AYOADE 2009. Another study demonstrated the efficacy of pentacillin in acute abdominal pain, but it was associated with delay in diagnosis and treatment. That is 2009. Conclusion. Mr. Vice Chancellor, I have highlighted the role of my research work in elucidating the body, clinical characteristics, and changes and challenges of care in surgical oncology in Nigeria, with emphasis on breast cancer. I have also highlighted treatment outcomes of some life-threatening surgical conditions, some of the challenges faced, and some peculiarities of our population that led to undesirable outcomes. Recommendations. Mr. Vice Chancellor, I wish to recommend as follows. 1. Health education commencing at the primary school level should be incorporated into our school curricula at all levels, given the deplorable health-seeking behavior of the people. Most patients present in the hospital late, and this constitutes a major cause of morbidity and mortality of the sick. 2. Breast cancer screening program should be established with adequate provision for treating identified cases. Collaboration with non-governmental organizations should be encouraged. 3. The scope of the National Health Insurance Scheme should be expanded to cover most citizens, including all civil servants. Special provisions may be made for the diagnosis and treatment of cancers, including infrastructure such as radiotherapy, training, and remuneration of workers in the cancer space, and procurement of effective antitoxic medications and other therapeutics. 4. Special incentives like better remuneration and special allowances should be provided to encourage subspecialization in the field of oncology by physicians, surgeons, pathologists, radiotherapists, pharmacists, nurses, and others involved in the care of cancer patients. 5. Special intervention fund for cancer care, like the recently introduced cancer health fund, should be expanded to reach all cancer treatment centers in Nigeria. 6. Palliative care services should be improved by establishing units with well-trained and well-motivated personnel with specialist allowance to provide needed services. 7. Development of less invasive procedures such as interventional radiology, endoscopic and laparoscopic surgery to facilitate surgical propagation of advanced disease. Last but significant, the general improvement in the people's socio-economic status will reduce the mobility and mortality of the sick. Acknowledgements. First, I give glory to God Almighty for making today a reality. My special appreciation goes to the Vice Chancellor of this university, Professor AYOADE Olayinka Johnson Agbola, who invited me to join the search for breast cancer control in Shagamu, on Nigeria and beyond. Other members of the management of the university are also deeply appreciated. I'm sincerely grateful to members of staff of Faculty of Clinical Sciences for their steadfast support. I also thank my colleagues in the Department of Surgery, both in the university and OLABISI ONABANJO University Teaching Hospital, Shagamu, for their unwavering support. I also appreciate the Chief Medical Director of OIT, Dr. Olubunmi Mutulayo Fatugashi, and other members of our management team. I'm particularly grateful to the Medical Records Department staff for their support in my research activities over the years. My profound gratitude goes to Professor AGO-IWOYE for his editorial assistance and useful suggestions during the preparation of this lecture. I remember the late Professor Adebayo Adeyemo of Ibadan University Teaching Hospital Complex, who offered me a supernumerary residency training post in 1987 when every training slot has been filled. I also appreciate my other trainers and fellow trainees at OATH and beyond. I thank most sincerely Dr. Kunle Obadilo. Can you stand up, sir? This is the audience. Who got me interested in surgery? Dr. Akim Olusimade and Mr. Shola Taiwo for their mentoring. I'm grateful to all my friends, particularly Dr. and Mrs. Oluwole Pukoy. Can you stand up, please? Who was the first to celebrate my elevation to the seat of full professor in the university? Others are Mr. Dr. Tunde Omoyimi, Mr. Bashiru Elebeji, Dr. Michael Tunde Olomoyo, and Mr. Rafael Braibo, each of which who contributed to the success we are celebrating today. Dr. So Vladi, a brother and a friend, I appreciate you for your support and counsel over the years. Is he here? Dr. Bless. My gratitude goes to my classmates at Government College Ibadan, GCI 697375 set, currently led by Mr. Leke today for their support and management. Can you stand up, please? 6973. Thank you. I also appreciate the Baptist family from First Baptist Church, Shagamu, my pastor, Reverend Julius Taiwo Adeola, and the children from our school, Remo Baptist Academy. Can you stand up? Thank you for coming. And also members of YMCA led by Dr. Iye. I appreciate all the princes and princesses of the AYOADE family from Akinsho ruling house of Omosha Adus Compound, Kotoro, Abeokuta. Can you stand up? My prince and princesses. My gratitude also goes to my in-laws, the Shoega family of Ifemuremu. I cannot but remember two people who contributed immensely to making me who I am today. My late mother, Mrs. Susanna Yakoyayori, and my late sister, Evangelist Adebusola Owujori. who are responsible for my education. How I wish you were here, but I take solace in the fact that I turned out to be what you wanted me to be. I appreciate my elder brother, Dr. ADETERU, AYOADE, and his wife, and his stand up, for all their care and support over the years, and all my other siblings. To my children, Adebanke, Stephen, Adedamola, Treasure, and Ademigo, I cannot but appreciate that you have been a constant joy and blessing to me in all ways. I thank you immensely for always making me happy and caring for my descendants, my grandchildren. Lastly, I cannot help but appreciate my wife, Mrs. ADETERU AYOADE. The share of my name, the being at the Kalawe. As described, one of my classmates described us as that. Dr. Dubode is here. Because the two of us being at Kalawe. God made us for each other, and all I have achieved would be impossible without God and you. I thank you for your steadfastness, complete devotion to our family, and selflessness in all its ramifications. Mr. Vice Chancellor, other principal officers of the university, distinguished ladies and gentlemen, I thank you for your patience.
Destiny, I have waited patiently. I have vision, though I believe. I know I can count. Stand up for the champions, for the champions. Stand up, stand up, stand up for the champions, for the champions. Stand up for the champions, for the champions.
Thank you. You may have your seats, distinguished ladies and gentlemen. Once again, on behalf of the Vice Chancellor, the management staff, and entire students of OLABISI, ONABANJO University, we want to thank you most heartily for attending this 117th inaugural lecture. We thank you for taking the pains to drive down to AGO-IWOYE and to see our beautiful campus here today. We wish you a safe journey back to your respective destinations. Shortly, I'm going to ask the Vice Chancellor to declare this ceremony closed. But before we do that, we cannot but mention some individuals here who we're most delighted to have. Indeed, we are most delighted to have all of you here present, but I must thank especially the KBC and the Olori of we thank you very much for coming, Olori. We appreciate your presence here. I must also introduce Professor J.A.K. Makinde as the former Vice Chancellor of Bangkok University in Shoreham. We thank you for coming, sir. Also, we have in our midst the former Provost of this of the Obafemi Awolowo College of Health Sciences, Professor Shamsidin Ogun. It's good to see you again, Prof. We thank you for coming. Professor Olushoga, I can see you there. We thank you for coming. Professor Olariwaju, we thank you for coming. Dr. Kukoyi, it's good to see you again. We thank all of you for coming here today. We wish you safe journeys back to your respective destinations. Please, distinguished ladies and gentlemen, as soon as the Vice Chancellor declares this ceremony closed, I implore you to please stand and remain standing until the procession at the high table exits in reverse order. We plead that you do that for us. We also ask the wife and the children of the inaugural lecturer here to please immediately we exit to join us outside, just as we exit now to join us outside. Once again, we thank you very much for coming. May I now ask the Vice Chancellor to please declare this 117th inaugural lecture closed.
Once again, the principals of the university, members of Senate, other members of the university committee are present, KBC, and other related events, on behalf of the Senate of this university, I hereby declare 117 inaugural lecture closed.
Shall we all rise and remain standing as we have the reception moving out of the hall. Thank you very much. Thank you. The family of the inaugural lecturer should please join the reception. Thank you very much. Distinguished ladies and gentlemen, all invited guests, we wish you journey masses back to your various destinations. Thank you and God bless.
Appreciation, mo dúpẹ́ oníbùwọ̀ rẹ̀.